Hello, listeners of the Retina Channel podcast. Welcome to episode 80 of this series. I can't believe this is episode number 80, and it's been a fun journey since October of 2017. And I've really enjoyed doing these publications and talking to these authors. And I hope we keep going with more episodes for you guys. Well, today we are back with another episode published by the American Society of Retina Specialists, and the lead author being Dr. Andre Witkin, which is our guest today. This was published late last year, and it was subsequent to a presentation by Dr. Witkin in the American Society of Retina Specialists meeting in Seattle. And it talks about an important safety topic of retinal vasculitis following with injection of pegcetacoplan for geographic atrophy. You may know pegcetacoplan is one of the novel therapeutics that was developed for geographic atrophy in age-related macular degeneration. And there were some concerns raised a few months after this drug was approved in the US about cases of retinal vasculitis that were following the first injection of this drug for patients. Dr. Witkin will go over the case reports and the details of the article, and also give us some updates about what we know so far about the incidence of retinal vasculitis following pegcetacoplan injection since the article was published late last year. Some background about Dr. Witkin. He's of course the chair of the ASRS REST committee, which stands for Research in Safety and Therapeutics. He's been a member of the REST committee since 2017. He is an associate professor at Tufts Medical Center in Boston. He is in fact the vice chair of surgical services for the department and director of the retina services, and the co-director of the clinical research and co-director of the surgical and medical retina fellowships at Tufts. He did his medical school at Weill Cornell Medical College, and also did his residency at Tufts Medical Center, and that was followed by his fellowship at Wills Eye Hospital in Philadelphia. He's an active researcher, very prolific author, more than 100 publications under his name, and he has won the ASRS Honors Award and the American Academy of Ophthalmology Achievement Award. I'm sure he will have many contributions to our field in his career, and I thank him and the rest of the REST committee for publishing these issues and associations and bringing the issue of safety to forefront so we can all serve our patients better. Well, without further ado, this is Dr. Witkin. Dr. Witkin.
Hi.
How are you?
I'm good. How are you?
I'm very good. You and I actually first met probably about 15 years ago almost. You probably don't remember. At Wills.
Okay.
You were,
I
think, first-year fellow. You were a first-year fellow, and I was a resident from McMaster University doing elective there. So I spent some time. It was you and
Alok,
Nick. It was Nick London.
Yeah.
It was who you were the fellows, and then I spent some time with you guys many years ago.
Yeah, there's a number of Canadians that come through. They have a close connection with Canada.
Yes.
A long history of training Canadian ophthalmologists.
That's right.
Yeah.
Well, Dr. Witkin, thank you for coming to Retina Channel podcast. I really appreciate you being here and talk about this report that you published late last year on behalf of the REST committee, ASRS REST committee, talking about pegcetacoplan, retinal vasculitis, and usually obstructive vasculitis. I think very important, obviously. I remember last year in ASRS, you presented the results, and then you published the results shortly after. This is an important topic. Here in Canada, we don't have access to pegcetacoplan yet. It's not approved yet, but obviously you're closely monitoring your reports and also what we hear from the States. Very promising category of medication in terms of what we can do for dry macular degeneration, but but obviously concerning as well when it comes to side effects like that. So for the listeners and the viewers, the title of the article we published is called Retinal Vasculitis After Intravitreal Pegcetacoplan Report from ASRS Research and Safety in Therapeutics or REST Committee, which you lead. So I'm excited to talk about this article. You present 14 eyes of 13 patients who all presented after the first intravitreal pegcetacoplan injection with severe retinal vasculitis, and it was usually obstructive obliterative vasculitis. Many of them had very unfavorable outcomes. So I was hoping you could maybe discuss that, what you present in this article, not each patient specifically, but what we should kind of take away and what you have learned so far since you published the article.
Yeah, well, I really appreciate you inviting me to speak with you today. It's a really hot topic right now, a topic of a lot of interest to all of retina providers, because we have these drugs now that we can use to treat a disease that never before really had anything to offer patients. So yeah, I mean, there's been a lot of excitement around these new medications for a relatively common disease. You know, I think when the drug was launched, pegcetacoplan, a year and a half ago, a lot of us were really excited to start offering it to our patients. And then, unfortunately, relatively quickly, the REST committee, which is an adverse event reporting system through the ASRS, the REST committee sort of looks through these adverse event reports, and we started to receive reports of severe vision loss following pegcetacoplan, and there were a number of reports that kind of came in, one right after the other, and that prompted us to give that talk and send out alerts to the ASRS community about this potentially devastating side effect. You know, since that talk, we then collected a few more cases, as you mentioned. It's hard to evaluate these cases based on adverse event reports from physicians, because we really need to make sure that what's being reported is indeed what we would agree on as being retinal vasculitis or whatever adverse event you're trying to define.
Yes.
So because of that, we actually recruited some well-known retina and uveitis specialists from around the country to look through the imaging and just to, double check and confirm that what we're calling retinal vasculitis is that. And, that's how we really came up with the numbers that were generated in that paper. I think, some of the really important characteristics is that, like you mentioned, all the patients had retinal vasculitis after the first injection, and that's a pattern that's continued to be seen from other people's presentations and other reports that have come out since our paper. It still seems to be the case that it's a phenomenon that happens after the first injection, and it suggests that there may be some underlying, if this is indeed an immune response, that there may be some underlying immunity to the drug. That's a theory, anyways, that seems plausible, where some kind of immune response is stimulated, but there's propensity in some individuals to it. The appearance of the vasculitis is a little bit different than vasculitis we've seen with other drugs, like with Beovu or with faricimab, where the involvement of the retinal vessels is mostly arterial. You get patches of retinal whitening as the sort of predominant feature, whereas in the pegcetacoplan related cases, it's much more hemorrhagic. It seems to be more on the venous side, and looks more similar to vancomycin associated vasculitis, which is something else that I have been pretty involved with publishing about.
I remember that. That was a few years ago. We reported on vancomycin related.
Yeah, and so it seems like there may be sort of different kinds of immune responses
Mhm,
depending on what drug is causing the
mhm.
vasculitis,
And
and this seems more similar to the vancomycin, which also was in patients who were just getting their first eye cataract surgery, and they never, they hadn't necessarily received vancomycin in the past, and then they get
interesting.
the cataract surgery and develop this severe vasculitis as well.
Very interesting. Very good. And the timeline for this is about 10 days or so since
Mhm.
pegcetacoplan injection. So if not, it's
Yeah,
not.
the average was about 10 or 11 days, and the range was anywhere between like 1 week and about 3 weeks or so.
Mhm. And the end two eyes had to be nucleated eventually, and the rest did not do so well. Um, so do you think this drug you mentioned that in the article that it's not a regular antibody. These are pegylated peptides, so essentially the structure is different. Could that play a role, or is it because of inhibition of complement that we may get these
Mhm.
things? In other words, is it the actual work of the drug that does this, or is it a side effect to the peptide?
Yeah, I mean, in the article, we proposed three possible mechanisms. One is it could be a immune response, like I was just mentioning. I think that's
Mhm,
probably the leading theory as
mhm,
to what's happening is some kind of immune response to the drug or some component of the drug.
mhm,
And as you say, there's a peptide component, and then there's also a PEG component, and the immune response could be to either part. For PEG, PEG is something that has a lot of heterogeneity. It's sort of a word that describes a whole bunch of different molecules. It can look very different, a
mhm.
whole bunch of different stuff. And PEG is in all sorts of substances that we use all the time: foods, hair products, gels. It's in the COVID vaccines.
Oh,
It's in all sorts of stuff. So the in fact, if you test the general population for anti-PEG antibodies, the prevalence is very high. It's over 50% of people have anti-PEG antibodies of some kind.
interesting.
And so it's possible that that might play some role. It's just hard to sort of parse that out and figure that out. But certainly, and some kind of immune response is sort of probably the leading theory. Another possibility, like you just mentioned, is it could be related to the mechanism of action of anti-complement. And the reason you say that is because in people who are complement deficient, they can actually get a lupus-like syndrome where and vasculitis is included
Mhm,
in lupus. There's some kind of immune complex formation that occurs in people that are complement deficient because complement plays a role in clearing immune complexes in your body. So if you're complement deficient, then you maybe get some buildup of immune complexes, and perhaps that could play a role in
mhm,
vasculitis. And then another last possible theory that we talked about is blocking complement does uh, cause you to be immunodeficient, so you're more prone to getting infections, and
mhm.
that's a known problem with any complement and systemic complement inhibitors that they're prone to certain kinds of infections, especially with encapsulated bacteria.
Yes.
Um, and it's possible that this may represent some kind of infectious etiology.
Mhm,
And the presentation is unusual because the immune system has been modified inside the eye. And so
mhm.
maybe this is an unusual presentation, but of
Oh,
an infection. But we don't necessarily think that's the case because for a few reasons. One is a number of patients did get tap and inject, and no organisms were found. Another is that there's also been reports of eyes that just present with endophthalmitis as a normal presentation.
mhm.
Um, and the a bunch of the characteristics are unusual. The fact that it presents so late, is another strange thing. And then the other thing is some people have proposed that if, well, at least with systemic complement inhibition, the patients that do get bacterial infections actually present in a more fulminant way because they're immunocompromised, and then it's like a much more
That's real
fulminant kind of
infection. Yeah.
infection. So as far as we know, there's been no definitive proof that infection plays a role in these particular cases, but certainly that's something to keep in mind. And also it's really important for an individual physician to keep it in mind when they're seeing this kind of problem or any kind of problem after an injection. You always have to think about an infection, and if there's any thought about that, it's probably prudent to treat it as an infection just in case, because
And you
certainly we
mentioned
know
some
that
of them
and we know that there are also cases of endophthalmitis from lots of different things that have been reported in the literature that present as retinal vasculitis too. For example, like early streptococcus infections can present as retinal vasculitis early on, and then they often quickly go on to more fulminant picture. But it's really important to keep that on the differential and to treat it as a possible infection if you believe that's a potential etiology.
Gotcha. There was a patient in your series that had pegcetacoplan in one eye, and a few days later had avacincaptad pegol in the other eye. What happened to that patient? So did they get same reaction to each drug in different eyes, or they did not do to that?
This is like an enigma, this case. I think this case has generated a lot of discussion for many reasons. One, first of all, the patient had Stargardt's disease, so it was an off-label use of both of the drugs. The second is that this similar kind of retinal vasculitis occurred in both eyes, and even though each eye received a different drug. So there's some people wonder whether perhaps it could represent more of a class kind of effect potentially. Certainly that's a big concern. And as far as we know, that's the only case of vasculitis that's happened with the ACP drug. ACP is also pegylated, but the peg is different. Like I mentioned, there's a lot of different kinds of pegs. I mean, it can look like millions and millions of different things, configurations, and the peg that's on that is different than the peg that's on pegcetacoplan. And then also there's no peptide component either. It's an aptamer. And so it's quite a bit different structure, and it's hard
It's an RNA kind of molecule, isn't it? It's like a pegylated RNA.
Correct. Yeah. So the structure is very different, and it would be strange for the same immune reaction to be stimulated by both drugs, but certainly it's possible, or maybe there's some other component within the what's being injected into the eye that might be playing a role. But as far as we know, that's the only case associated with that drug, and it's still kind of an enigma as to what happened with that case. But that's a really devastating case, and the patient lost the one eye that was injected with pegcetacoplan, and as far as I know, has vision loss in the other eye, although still has the other eye. But one other thing that case demonstrates is how important it is to wait before treating the fellow eye. What we would suggest is to wait at least a month before considering treating the other eye.
Yes, it's a sad case, educational for us and mind-boggling, but it adds to the puzzle. But I'm sure we'll learn more in the next few years as we use more of this drug. And so what's happened so far since you published the committee in the interim, the past 6 to 8 months? Have you been receiving more reports, or in terms of frequency? What's the status right now?
Yeah, we get this question a lot. It's, again, we want to be a little bit careful about what cases we're definitively calling whatever disease vasculitis or whatever else is happening.
Yes.
What I can tell you though is that there's been nothing to change what our knowledge of this problem that's happened. Hasn't been a huge increase in cases or anything like that. It seems like it's a rare problem. It continues to be a rare problem. There's reports of possible vasculitis here and there, but hasn't been this exponential increase like we saw with Beovue, where the ASRS also, the REST committee was involved with reporting about that, and that was like an exponential increase in cases of vasculitis, and that's why there were so many subsequent reports about it. Whereas with this, it's rare and continues to be rare, and that seems to be the case. And again, like I mentioned, it seems like, as far as we know, it happens after the first injection. It's not like with Beovue where you may do a few injections before you get the vasculitis.
Very good. And this may be not a fair question because you're not in distribution of this medication. Do you know the incidence or the frequency of how many injections has it been reported in, like 1 in 1,000, 1 in 1,000,000? What rate is it as far as we know?
Yeah, there is some challenge to knowing what the incidence is, because it seems like it's on a first injection problem. It's really most important to know how many patients have been treated and not so much how many vials have been distributed or used, because you may have patients that have, once they've gotten the 1 injection, they're safe, and then they can get 10 more injections or whatever. And so you don't necessarily want to count that as 10 injections. You want to count that as 1 patient.
Right.
And so
number of patients involved, really, not the number of injections. Yeah.
Exactly. Yeah. So on a per patient basis, it's been a little bit harder to figure out. I think that's information that will be coming out in the next year or so, because now there's permanent J codes for the medications, and so they can look at the per patient distribution a little bit more now. I think some of the data that is helpful is with the larger private equity data that's been talked about recently. There was a report that came out of the RCA group, which is a very big private equity group, where many thousands of injections have been done, and then they can just look at their own database at how many patients have received medicine. And it seems like from what's been reported from them, it's probably on the order of like 1 in 3,000 or 4,000 patients maybe getting the vasculitis, something like that. But because it's so rare, it's going to take a lot of data to really figure it out, the exact number. But what I would say is, and what I tell patients, is quite rare, probably rarer than endophthalmitis, or maybe similar to. And so these are rare things, but they can be potentially devastating.
Yeah, but that's helpful to know. Someone who hasn't used it here in Canada, so I'm dealing with 1 in 3,000, 1 in 4,000 per patient encounter, and versus in Beovue, you said there's been an increasing incidence as the drug had been used, but here it seems to be
and also with Beovue,
rare.
Also with Beovue, they were able to go back into the study, and they found actually all these cases of vasculitis, and so it's a much higher, that's with a much higher incidence. It's like 3% or something like that of Beovue injections can get vasculitis. So, and again, with Beovue, difference is that it's per injection, because you can get it after not just the first injection, but there can be subsequent injections before the patient presents with vasculitis.
Very good. Very good. That's great. Anything else you want to teach us, Andre, about this drug? I think it was fantastic. I learned a lot, and these are the reports that you folks do, and all the data you gather. It's tremendously helpful for the rest of us. It establishes some safety guidelines and what to expect. So I'm very thankful to you and the rest of the REST committee for doing this important work. So anything else you wanna add to our discussion?
Yeah, well, just like you said, I think a lot of us feel that it's really important. That's the reason why the members of the REST committee are on there, is because we're really interested in sort of figuring out problems that may not otherwise be figured out or shared with the community. And we really depend on physicians reporting to us. And adverse event reporting can be onerous, but I think it's really important, and I think it's important for us all to keep that in mind if we see a problem, especially with a new drug where we may not necessarily know that much about adverse events. It's important to keep our committee informed and the drug companies informed as well, because they're also sort of responsible for tracking the data. It's a requirement by the FDA as well. So
Yes, wonderful. Well, thank you very much, Andre, for giving me the time and coming to the Retina Channel podcast and doing the great work that you do and teaching us. And I appreciate it.
oh, it's my pleasure. Thanks for inviting me.
It was a pleasure. Well, folks, this wraps up episode 80 of the Retina Channel podcast. I hope you enjoyed it and this was educational for you. I personally learned from it a lot, and it kind of put my mind at ease a little bit that the incidence of retinal vasculitis following pegcetacoplan injection is 1 to 3,000 to 1 in 4,000 new patients, and it's only significant if it's going to show up, it's going to show up on the first injection, which is kind of reassuring, but still something to consider when we want to start a patient on this injection. Well, until next episode, I wish you all the best. Enjoy your summer and take care.